So Dr. Miller will next be talking about extraocular muscle biopsy to aid in diagnosis and strabismus etiology.
So I love this. I love that we had that question about did you consider biopsying the muscle? Because that's actually another area that I feel is actually a very much an underutilized diagnostic tool when having patients and you're trying to understand what the cause of their strabismus is. So I have no conflicts of interest. So just to sort of summarize what I'm going to be talking about for this talk is I'm going to sort of give some sample case presentations and then also go into a little bit more about my technique on how I do muscle biopsies. Then also some important considerations when you're dealing with how the pathology manages this. It gives sort of summarizing thoughts at the end. So the first case I'm going to present to you is this a gentleman. He's a 38-year-old with a history of smoldering IgG myeloma that had been followed for many, many years, the known MGUS diagnosis. He had a history of childhood strabismus, and he, based on a slit exam, it looks like he might have had bilateral lateral rectus recessions at some point in the past for childhood exotropia. He had a 1-year history of progressive worsening of exophthalmos and worsening exotropia without diplopia. And he had unfortunately, multiple medical issues since childhood, gastroparesis, multiple polyneuropathy, to name the few. He had ultrasound done looking at the extraocular muscles, and it showed that there was diffuse enlargement on all muscles. And then thyroid labs were obtained, and which were all normal. There was bone marrow biopsies that showed a 10% plasma cells, but then additional attempts to try to better define his condition showed, like with a fat pie biopsy, was all negative. So MRI imaging was done, and you can see on this image here that while the ultrasound showed that they were enlarged, I wasn't overly impressed on MRI imaging on the size of the extraocular muscles. So going into this, we were trying to sort of get an understanding about what was going on in his situation. This is sort of the gaze photos for him. You can see, if you look at him straight ahead, he's got this constant exotropia, but you can look in his side gazes, left and right. There's both underaction of the lateral and medial rectus muscle in both eyes. And then up gaze, he has reduced up gaze. Down gaze is improved, but still abnormalities there. So you can see on the motility here, just the noticeable elevation deficiency combined with the exotropia with a small right hypertropia. So what was done is that we had bilateral medial rectus resections were performed, but at the time of that resection, also the muscles were biopsied. The medials were actually biopsied and sent to ocular pathology for analysis. So this is the PAS stain, and also had Congo red stain, which you can see demonstrated skeletal muscle replaced by dense fibrosis tissue with focal amyloid deposition. And you can see on the dichromism on the apple green bifringence test, they turn to orange. You get to identify that this is amyloid deposits seen under a polarization. So again, the apple green bifringence, that's that key term that we all learn in ophthalmology residency, which is one of the key factors looking at amyloidosis. And that helped identify the source of his strabismus that progressively worsened over the previous years. Second case to present is a 50-year-old that presented with a chronic recurrent binocular horizontal double vision. He also had pain and discomfort in his eyes. The onset of this was 15 to 20 years prior, with a progressive worsening over the last few years. He had extensive workup prior to coming and seeing me, and he presented due to worsening double vision. He had an MRI of his brain orbits, which was all normal. Orbital ultrasound showed extraocular muscles were normal in size. All the thyroid labs are routine, the autoimmune labs, everything completely normal. Myasthenia labs, normal. He also had a myasthenia challenge with a Messinon. Again, it was normal, no change. Steroids, no change. Neurology ended up doing an LP, which also was normal. His motility patterns is as such, and this is his distance fixation motility measurements, and they were full with and then his esotropia was 30 prism doctors. So I ended up doing a bilateral medial rectus recessions. At the time of surgery, his forced ductions were actually normal, but because of this unknown factor that seems to be more chronic combined with some pain, we ended up getting extra-ocular muscle biopsy of the medial rectus, which were sent to pathology for analysis. So on the PS stain, and then also with alcinine blue stain, you can see that it ended up demonstrating glycosaminoglycan deposits, which are these light blue, the coloration and the skeletal muscle atrophy, which is the pink fibers. This is all consistent with Gray's orbitopathy. So he is actually a case report, actually is reported in the literature of euthyroid thyroid eye disease, which you can have. What's interesting about his case is that it wasn't for about 3 years later, he actually ended up developing full-blown thyroid eye disease with the classic typical findings of exophthalmos and additional restrictions. Unfortunately, his strabismus came back at the time, but at least, but it just goes to show that you can do through biopsy identify with autoimmune labs, everything being normal, actually thyroid eye disease in its earliest point of potential clinical presentation. And then the third case I wanted to sort of present is a 38-year-old individual that presented with painless intermittent binocular double vision. This is something that he had more issues at night. This onset was 5 to 6 years before coming to me, and really affected his driving. He had a history of hypothyroidism and thyroid nodules. There's a family history of thyroid eye disease, but he had no other systemic complaints. Because of this, thyroid was really definitely sort of on our mind. He had MRI, which the brain in orbits, which is all normal. Orbital ultrasound was also normal. Thyroid labs, all both routine and autoimmune, all normal. Myasthenia labs, normal. But he had moderate to high myopia bilaterally, approximately -7 sphere. So this is sort of his motility pattern. You can see that he had this underaction, abduction in both eyes with a constant esotropia that was comitant in nature. So even though we had this underaction and side gazes, his overall deviation was actually fairly comitant. He ended up having bilateral medial rectus recessions of 5, and forced ductions, again, at the time of surgery, were actually surprisingly normal. So that led to sort of, okay, normal forced ductions. At the time, we ended up doing an extra-ocular muscle biopsy, and this was sent to ocular pathology for analysis. So we had a Gomeroi trichome, which was actually on the side performed, and you can see this is what a normal result looks like. And in his case, this was his fibers on the right, where you can see this was actually abnormal, and you can see the red area in that eye is actually ragged red fibers, which gave us confirmation this is an unknown mitochondrial disorder. So with this, I'll throw this out there just as far as what besides muscle, what other tissues would you expect to suffer the most damage from mitochondrial order defects? So maybe someone, a resident will be brave enough to kind of jump on and maybe give us an answer later. But the idea behind this is that, again, we had this unknown mitochondrial disorder. This led to being sent to genetics, and he's still in the process of having that fully worked up and evaluated. But again, doesn't appear to be like a myasthenia type appearance. So I wanted to sort of talk a little bit about extra-ocular muscle biopsies and sort of my technique, and also some concepts about the biopsy. Most muscles can be biopsied relatively easy, with the exception of the oblique muscles. The superior oblique is way too far in the orbit to really access any muscle fibers, and the inferior oblique has the reduced risk of bleeding, and is actually more prone to actual scarring and orbital scarring. So it tends to be not muscles that I want to go and do biopsies on. But the goal of any extraocular muscle biopsy is to obtain good tissue and to help guide you in diagnosis. And while all the rectus muscles are options, I find the lateral rectus is actually a little bit less ideal because the muscle fibers, due to the arc of contact and the tendon, they're much more posterior to the insertion than the other extraocular muscles. So I tend to do less biopsies of the lateral because it yields a much lower yield of information due to the fewer myofibrils present on the biopsy specimen. So when looking at this, then this is sort of an example of a right eye medial rectus biopsy. I find that when you're choosing the location of biopsy, the area outlined here in the black is sort of the best targeted area where you want to shoot for. It's the center of the muscle. And then the area outlined here in the red are actually less desirable. Whenever you go and you're biopsying, again, let's say for resections, it's tempting just to send the stump because that's tissue that you'll be throwing away anyway. But it tends to have much less myofibrils near the insertion and actually is much less helpful, and you get less help, information from the pathology department because it just is mostly tendon fibers at that location. Biopsies at the edges of the muscle, while it seems like that would be an easy place to get it, actually can destabilize the muscle and cause puts it because of the forces on the eye, can actually put it at risk for splitting or even stretching. And so again, center biopsies produce a good sample of the muscle, of good tissue without destabilizing the muscle and the work and how the muscle works and moves. So my target amount of muscle is about 6 millimeters away from the insertion, with a length of like a strip of approximately 8 millimeters in length and a width of about 2 millimeters in size. So how do I go about doing this? Start off usually with like a Stevens or just a small hook, and use that to sort of break through at the first point, and then I use that to slide posteriorly on the muscle to create that first sort of break in the tissue. And then I'll repeat this again for the other side of the strip and sort of use that Stevens hook to starting at approximately 5 millimeters from the insertion and going backward, as you can see here. So then I will use a Jameson hook, and I'll use that to hook between the two between the two segments, so that it allows it to be better isolated. And then I'll use that hook to slide farther back to create better separation of the tissue of that strip from the surrounding muscle, as there's often aspects of tenons that get caught up into the actual area. And then I'll use the Stevens hook to then tent up slightly that strip, and then use Westcott scissors to come across the muscle and then snip at that point approximately 5 millimeters from the insertion. That creates the 3 parts of your strip, but when this happens, the biopsy piece will retract slightly, but not far, but will retract slightly posteriorly at the time of that cut. That's okay. This is the one time that you're going to want to use your forceps. I end up using Thora tissue forceps because anytime you grasp that muscle, you're going to have a crush artifact. So if you can hopefully just grab once and just the very edge of it, that would be ideal. And then you gently pull anteriorly. Then lastly, you make the last incision by sliding the Westcotts so that the tips of the Westcott scissors are on the top side of the muscle as you slide backwards. And you can literally almost, as long as you know that the tips of the Westcotts are on the top side of the muscle, you can, in essence, sort of blindly cut that last segment of the muscle, which then allows that segment to be then sent off for pathology. That specimen, which I'll get into a little bit more, I usually put on a piece of Telfa into a biopsy chamber and liberously spray with BSS onto that tissue and also on the Telfa to provide a good moisture. And then lastly, that defect, I will often sort of close with 8-0 vertical sutures just to kind of pull the defect together. And then what I find is the most interesting about this technique is that you do the actual surgery as you would have otherwise done. You don't change the dosage. You know, I found that you take this segment out and you can safely do strabismus surgery at the time of surgery, and the effect on the surgical dose is not affected at all by doing a biopsy. So I've done both resect, recess, and this was my crude drawing on my phone at the time whenever I was showing a colleague of mine on how I do it. And this is sort of a quick summary of sort of the steps of what I went through to go ahead and to do this. So whenever you do this, it's real important that this is a partnership with your pathology department, because we're dealing with a very, very small amount of tissue. And are they prepared, and are they able to basically handle that kind of small amount of tissue? And also discussing the transport of it, the timing of them receiving the specimen, and then what do they and how, making sure that it's managed and handled correctly. Based upon your suspicion about what may be going on, guides you on what you might use to have them focus their tissue analysis on, because often they can't do it on everything. If you're trying to do cytology, often that's the one, that whole piece would be used for cytology. If you have a bilateral procedure, I do bilateral sampling, because that gives more tissue to then expand the spectrum of what they can test for. Electron microscopy, special testing there, and then you want to prioritize, what you're going to have them look for based on your level of suspicion for different conditions. Again, specimen collection, you want to try to minimize crush artifact. So just grabbing that edge of the tissue just once with the forceps will be important to then allow the most tissue. Again, if you think about it, you're grabbing that area that's closest to the tendon. So if you are getting a little bit of the tendon that may be captured within the actual tissue, it tends to be less critical on the specimen. So then how do you store it and deliver it? As I mentioned earlier, they're typically sent fresh, and that's without any kind of fixation. That expands the ability of what the pathology department can do with this. And then again, I cut out the TELFA material into a round circular, and then drop that into the bottom of the specimen tube after placing it on the TELFA. The fresh delivery allows it to be potential for cytology and also electron microscopy analysis. And then the key is to really saturate it well with plenty of saline. And the goal is to have them process it at least within 2 hours of collection. And if there's any chance that there's any kind of delays, I've done these off-site so that we had to have a courier deliver it to the pathology department. But refrigerating it at the time of transport is helpful to maintain tissue viability. So sort of in summary, some adults, they have nuanced strabismus, and we have actually no known cause. And many of those patients end up having strabismus surgery. So extraocular muscle actually can be a biopsy, can be performed as an additional diagnostic tool to help identify maybe what the source of the strabismus may be. And I found that the medial rectus is actually an excellent source, but I've also done this on the inferior rectus, and then a little less common, but also the superior rectus. I advocate trying to avoid the first 5 millimeters from the insertion, because you get tendon, and that creates a little bit less as far as the fibers. And then the lateral rectus is less desirable, as there's more tendon and less muscle fibers. But most importantly, and what I find is most interesting, is that when I've done this and I do the strabismus surgery, including resections, and then I'll do the biopsy, I'll suture the piece together, then resect. I'll still send the anterior segment in addition to the middle segment. But even with that, I find that it still has the same surgical dose, even with resections, and you don't have to adjust the actual surgical dosage when doing a biopsy. So with that, I would like to, that concludes my discussion on sort of extraocular muscle biopsy, a little bit of a quicker presentation, but I thought it was very interesting, and open this up for discussion and questions.
Thanks again, Dr. Miller. Any questions?
I see in the chat box, Dr. Bugles has a question, and then I'll ask mine.
Okay, so Dr. Buglis asks, could a fine silk suture on one end of the muscle biopsy help in keeping it on a stretch to allow it from shrinking and aid in the completion of the biopsy?
Absolutely, you can do that. But again, what I found in my experience, because there's different ways that I sort of got to this point, and when you do that, there is going to end up still being some manipulation of the actual tissue from passing the suture. So you can do it, and it's a good way to, if you're trying to localize and sort of identify which edge is which. But when I talk to the pathology department, I've found that they don't really care. It's less helpful because usually if you're closer to the tendon, they can usually see that under the microscope. And so it tends the orientation of the actual biopsy is less helpful. But suturing that segment so it doesn't retract back posterior absolutely can be done. Although you, at the same time, you end up getting some levels of crush artifact just from the suture placement. And using the forceps by grabbing once and then cutting, you get, I think in my experience when talking to the pathology, very similar, maybe crush artifact level. And I would argue maybe a little bit less.
Okay, thank you. Dr. Aragantla.
So I've had only 2 occasions so far to do a extraocular muscle biopsy. The first time was a few years ago. I did it on the medial rectus. I don't know if your paper was published by then. I didn't know that the target area should be, you avoid the tendon and go deep into the muscle belly. But our pathology department sent back the report saying insufficient sample. And then I was like, this is the extraocular muscle. It's not like, deltoid or something. This is how many, it's only a few millimeters. Yes, that's what you'll get. Last year I did one on a patient who I didn't know beforehand, but when I was doing the second surgery, I thought I saw the lateral rectus was very atrophic in a child who had persistent esotropia. And it turned out to be actually a case of horizontal gaze palsy. And I should have actually sent her blood for Robo3 gene testing to, I've done that previously, sent to Elizabeth Engel in Boston. But this case, I sent the muscle biopsy. And again, I think I would have done a better job had I, known. One of my questions is, so it's akin to a split of the muscle that happens, and when we teach residents or when we're doing the surgery, we're always saying, be careful not to cause a split. And yet you said that it didn't actually affect your final outcome. So is it because there's enough sarcomeres or there is sort of regeneration there? Or?
It's a great question. It's something that I thought a lot about, and which is like most of the time, whenever the biopsy was being done, it was being done because of this. Well, this is a patient with strabismus, and so we have situations where I've had patients that come in with I think they believe is metastatic disease, and I've had one on a muscle, metastatic disease on a muscle, and you go in just the biopsy to help with diagnosis about the kind of metastases is this. But in these cases, these are patients that were coming in for really, it was strabismus repair potentially, and the biopsy was sort of a secondary thing that we added on. So the idea about why does it not seem to affect the actual dosage? Well, it's easier for me to rationalize on recessions compared to resections. That's the interesting part of it. And I don't think I would get too sort of, whenever this is more of, and I also have to sort of preface that I'm very, very spoiled in that I'm at Baylor College of Medicine and Houston Methodist. In Houston, we have an ocular pathology department, and they deal with small specimens all the time and are used to small specimens. What I found is interesting, though, is whenever I send a muscle biopsy, the eye department is the one that usually manages the specimen, but the person that they actually have read it is actually the more on the regular pathology side, pathologists that more specialize in muscle biopsies on the rest of the body, just because the ocular pathologists see very little. And And through that discussion with the ocular pathology department and the pathologists in general, it turns out we actually don't know a lot about extraocular muscles on the pathology side of things, especially in disease states. So there's a lot we don't know, and that's sort of an area of sort of an interest. And maybe as time passes over time, we're going to get more and more information. But really, it's having the pathology department figuring out is there a capacity there, and then if not, finding out this is when you can't send fresh, you'll have to do fixation, and having like the Engel pathology department's a great example of a place that could potentially process some of these specimens. I've had many patients who've had genetic assessment through their department also. So the idea of the why, again, this is where I go into my engineer mind, being a past engineer through my initial training. And I think there's a lot to do with it, the forces onto the actual globe and the eye. And when you're doing strabismus surgery, at least with recessions, you're changing the force and where the force is being applied onto the globe. So it may be the segment of muscle that you're taking out has an insignificant effect on the actual pulling of the muscle and the location of it, and by pulling it together. But then the summation of the forces as they act on the globe, they're still equally distributed because the segment's in the middle of the muscle, and then therefore you don't get a clinically significant effect. I think it goes also to sort of say that with strabismus surgery, we actually, there's certain people that just advocate small, medium, and large recessions. And then there's certain people that like one that I trained out with that actually was measuring strabismus recessions to almost to the 0.1 millimeters, which sounds crazy. But, it goes to show that the actual results in the surgery, there's a spectrum, and you can get really good results. And I suspect with the biopsy included, the impact is negligible on the actual effect on the alignment.
Okay, that maybe leads into the question from Vishali here. What type of post-op strabismic complications can be expected?
Well, specifically with this kind of procedure, there's definitely more hemorrhage, more bleeding. And so one of the things I didn't mention is that I also try to minimize any kind of cauterization until after the specimen has been obtained. And then I try to cauterize the distal narrow edge, because that might bleed a little bit. But inevitably, even if there is some bleeding, surprisingly, it's not a massive amount. And the splitting of the muscle and the sample orientation that I showed actually reduces the bleeding risk, because the more that you cut across the muscle is where the bleeding occurs, but then going front to back, more anterior to posterior, and in those movements, there's less risk of vessel tearing and less bleeding occurring. So I've always been relatively surprised at the time of surgery, actually not a lot of bleeding, but you will get some, and definitely there's going to be more postoperative hemorrhage. But as far as like discomfort, and it's the same effect, and I haven't found any other unusual complications in I'd say at least 3-4 dozen samples that I've done of extraocular muscle biopsy.
Dr. Miller, I have one question. Mm-hmm. I wondered about the thickness of the biopsy. So if we are taking muscle biopsy, not at the time of surgery, just taking before, just to know how this is related with the clinical condition. If we go for partial thickness, do you feel it would not be enough, the sample?
I do. I worry that it's not enough by doing a partial thickness, almost like a sort of a shave, and that and then also you're going to get more artifact, because you're going to get, in essence, sort of crush injury all along that track of doing a partial thickness biopsy. You get sort of the cleanest effect by getting the full thickness. And I've definitely had cases where even with sending specimen, it's not enough for even the ocular pathology department to be able to do the full analysis of what I would have liked. So, I do advocate more for the full thickness.
Okay, thank you.
Okay, a question from Dr. Hu, one of our residents here. For those who calculate recession to the millimeters, how do they account for vector changes? Sorry, a second. As the new insertion site on the globe is at a different angle.
I love this. This is actually, that was my first paper actually was talking about that I ever wrote was actually during residency. And It was actually titled, it was like called the torque vector model of strabismus surgery. And this is a time when we started getting more into the pulleys and the pulley analysis and how the pulleys might play a role in actual strabismus surgery and why we see what we see at the time of surgery. So my first paper was on the forces on the globe, and it was just purely because I was with a pediatric ophthalmologist, and he was real interested in the whole concept of this, but couldn't quite figure out how do you incorporate this. And then I had this sort of my engineering background. I was like, oh, I can just go and talk about, vectors and tangents and started getting into the math of it. And it really kind of led into maybe this understanding of what might be going on. And so we know that the pulley may play a role, but it's not a static position. It also moves. It's also why people that do strabismus surgery, at least on horizontal muscles, we do 1 millimeter recessions, you get nothing, you get no effect. But then as you get more farther back on the arc of contact of the actual muscle, you start getting more effect, which is why it's rare that I do any kind of recession less than 3.5 millimeter on a horizontal muscle. Because even more than that, actually, on a more maybe like 4 on a lateral. So because you get very little effect, it seems, on those first few millimeters. But then as you recess more, there's a little bit of an exponential effect. So the farther you recess, the more bang per millimeter you might get for actual effects, which is why I tend to not recess more than 6.5 millimeters on most of my recession. On occasion, I might get an infantile esotrope that I might do a 7 millimeter recession, but I rarely do because, again, after watching these kids and adults over time, when you start getting more 7 millimeters, they have a much higher incidence, at least in my hands, of getting a consecutive exotropia over time and then later in life. So I would attribute the vector changes maybe a little bit about the arc of contact. Also, the pulley does probably play a role in how the actual recessions work. Great question.
Any other questions or comments for Dr. Miller?
So getting back, myasthenia gravis, what other area does it affect the most? Getting back to that question I sort of threw out there earlier. So in addition to the muscles, the nervous system. So actually, that's a common place. That's why patients with myasthenia will often have sometimes cognitive challenges and issues because it can actually affect the nervous system too. So that was the last thing I'll throw out there.